Okay, good afternoon and welcome to the Logical CME third session today on CBC. We'll be covering the WBC and the platelets and fever part today. The outline of what I'll be covering is in brief the immunity part, the WBCs, what the WBCs are, total count, the individual WBCs, their increase, decrease, and then we proceed ahead to one important feature of eosinophilia and go ahead to another main topic, dengue and enteric fever, which should take about 20 minutes for that. And then we wind up by doing platelets and then general principles of how to order the tests so that we do not waste the patient's money on the test. And maybe we'll cover up IgG, IgM, different types of immunoglobulins, what is specificity, sensitivity, time permitting and all that. So now to dive deep into our first topic, immunity, which I'll cover very shortly. We have two types of immunity. One is the innate, natural or the non-specific. Correct? Innate, natural or non-specific immunity. It's an immunity which has been present since primordial time, even the most basic, the same animal kingdom organisms will be having this immunity who have organelles. So the cells associated with this innate, natural, non-specific immunity are the neutrophils, the monocytes, which turn into macrophages, and lymphocytes, particularly the natural killer cells, NKC. These are the cells of the innate or natural immunity. The other one is the acquired or the say adaptive immunity, which is the immunity which is how specifically against all organisms, whereas the innate, natural, non-specific is a immunity which will attack each and anything foreign or whatever our body considers foreign, will attack that. Adaptive is to a specific threat. So acquired and adaptive, and that the cells involved are only lymphocytes, and that too only two types, T and B cells. B cells or the plasma cells and T cells. B cells, plasma cells produce the antibodies which are become very famous during the COVID times, the antibody titers. Unfortunately, all of us lost with concentrating on this antibody part, didn't see the T part, lymphocyte T cells, the T cells which are the killer cells, which is a cellular mediated immunity, and this is the antibody mediated AB, this lymphocytes B. The cellular mediated antibody cannot be measured, and therefore it remains the same, immeasurable the same. So we presume that our vaccines have, or our infection has given us also a good amount of cellular immunity. Now coming to our WBC, the same. We call them WBC or call them leukocytes. Again, leukocytes, the same. Total, the same is count is 4 to 11,000 per cubic millimeter. That's the normal range. Alright, 4 to 11 this. Now leukocytes can be divided into broadly two parts, granulocytes and agranulocytes. Granulocytes, three: neutrophils, eosinophils and basophils. Agranulocytes, lymphocytes and monocytes. Now if we go into what has happened is below the leukocyte count you get the differential count, which is a percentage of in 100 represented to WBC cells, how much of neutrophils are there, eosinophils, basophils, lymphocytes and monocytes are there. So normal neutrophils is around 40 to 75, eosinophils is 1 to 6%, basophils is 0 to 2%, lymphocytes is 15 to 40, and monocytes is 2 to 10%. Now anything less than that goes into the penia part, as I've written out over here. Less than 40 will be neutropenia. Usually you will not encounter so much of this penias on this except lymphopenia, which got famous during the COVID times. So neutropenia is out, you get this thing, anything less than 40 count, and anything more is aphilia, neutrophilia, eosinophilia, basophilia. But when you come to the A granulocytes, it doesn't become lymphophilia, it becomes lymphocytosis. The terminology is different. Lymphocytosis and monocytosis. Here you won't get neutrocytosis, you get neutrophilia, eosinophilia, basophilia. Neutropenia is lesser, the philia is the greater part, and lymphocytosis, monocytosis is this part of it. Okay. Now,
so basic role of each cell.
Yeah. Now I'm covering each of the cells in individual things, and then we try and put it all together as a symphony. It's like an orchestra.
Correct.
All the cells put together, they have to play one symphony. You have to come to one diagnosis, not one cell alone. Okay. So neutrophilia, which is the increase in neutrophils, occurs in most of the pathogenic infections. Okay. See, most of my lecture I will be speaking only on the common conditions which are going to encounter. I am not going to list from the Harrison the 30-40 conditions which are there, which are very rare. We are not going to cover the same. So we will cover only the common things which we should be aware of and which is expected of us to be aware of. So we will cover that. So neutrophilia, increase in neutrophils will occur in any pathogenic infections. Pathogenic infection means pus. Pus means bacteria. So any bacterial infections, neutrophils are going to go up. Eosinophils will go up in two conditions: allergy and parasitic infections. Basophils will go up in type 1 hypersensitivity reactions. Type 1 hypersensitivity reactions. Okay.
So what is the type 1?
Yeah, hypersensitive reactions 1, 2 and all those are coming. It's a big topic. We'll keep it.
Okay, fine.
Time permitting, we'll
Fine. No
we'll discuss. Remind me at the end. If there's a time, the thing will go on to that. All those 1, 2, 3 types and all those. Okay. So yeah, next is lymphocytosis. Again, they will go up in most of the viral infections. Almost all viral infections, lymphocytes will go up. And in chronic infections like tuberculosis, which are long-standing. Okay. One place, can you remember where lymphocytes don't go up? One viral infection where lymphocytosis doesn't occur. Very famous disease. We can't forget that disease. Yeah. It just made our life upside down. COVID. You remember that NNR, the same term, NLR, neutrocyte-lymphocyte ratio. What used to happen in COVID was, initially the tests were costing about 5,500 rupees. So you could just go and order those tests left, right and center. So you have to go by other guiding principles of whether what the thing is. So one of the thing was NLR ratio, neutrophil lymphocyte ratio. Alright. So what happens is that this neutrophils increase a lot, lymphocytes fall. So when this NLR ratio, so neutrophils divided by lymphocytes, when this ratio goes anything above 3.3 or 3.5, it went in favor of COVID. Okay. It's just a neutrophils lymphocyte ratio. When the neutrophils, so supposing neutrophils were 80 and neutrophils were 90 and lymphocytes were 30, then it becomes
imbalance.
So 3:1 ratio came. So it's still on the border. 3.3 or 3.5 is the cutoff. So above that you could say yes, this looks like COVID. So this is the thing. Now, yeah, we covered up neutrophils because of the pathogenic thing. eosinophils, allergic and parasites, basophilia, type 1 hypersensitivity, lymphocytosis, again viral and chronic, this thing, monocytosis, again comes in chronic infections like TB. And in viral infections, when the body is mounting a response, the monocytosis, you will find that most probably it's the body which is the same reacting against the same, producing more monocytes. I'll tell you how it goes on. So in viral infections also you get monocytes towards the later end of the disease of the viral this. So I'll told you for each one individually, but now to round it up the other way around, going disease wise. So pathogenic infections, bacterial infections, only one, neutrophils. Okay. Chronic infections or inflammations, two cells, monocytes and lymphocytes.
Chronic
Okay.
infections.
Viral, lymphocytes. Okay. Allergic, both eosinophils and basophils. Okay. And parasites, eosinophils. Okay. So I have given you a classification both ways, either cell type and the diagnosis wise which cell will go off. Okay. Now we come to this. Yeah, and of course immunity again innate natural. This thing is only neutrophils, lymphocytes may natural killer cells, and monocytes in the innate part. Whereas in the acquired immunity is only lymphocytes, that too only T and B cells, not the natural killer cells which goes into that. Okay. Okay, now neutrophils are the most from abundant cells, the same 40 to 75% they are the same, and they remain in blood vessels for about a couple of hours. Their lifespan in the blood vessels is only about a couple of hours, after which they migrate into the tissues, and where they, if they are not utilized or they do not come into action, they normally go a programmed death within a couple of days, 2 or 3 days max. They have a programmed death called apoptosis, they die on their own. Okay. Now this neutrophils, if you take a cross section of the blood vessels, you'll see a central thing. You see this is the endothelial lining. You'll see a lot of WBCs attached out over here. A lot of neutrophils are attached out over here like this, and a lot of neutrophils are free flowing, with the blood vessels. They are just flowing like a water in a river. This a cross section of a blood vessel. So this is the blood vessel wall, endothelial lining, and inside this endothelial lining you can see this neutrophils attached. So these are called marginated neutrophils, and this is the circulating pool of neutrophils. What you measure in that WBC, in your CBC report, is this report. This, not this. Doesn't include the marginated. Plus, any guesses which is the most abundant cell in the bone marrow? Abundant cell in the bone marrow. See, all the cells are produced. All of these cells, including RBC, platelets, are produced. RBCs are in millions. These are in thousands, and WB and platelets are in lakhs. So, which is the most abundant cell? Most abundant cell you will find if you see under a microscope, bone marrow, the thing will be neutrophils. Yeah, they outnumber all other cells. They're so few in number, and the lifespan is so less, compared to RBC, 120 days. Though they are in millions, they are 120 days. These are just about, if you take about 50% as an average, the same, so maybe about 6,000–7,000 per ml, and they last only for a couple of hours. So they are most abundant. Now in the bone marrow, the mature, the same neutrophils are in large numbers, which can be mobilized at a moment's notice into this thing. So, moment you have a pathogenic infection, what happens is this neutrophils enter the circulation up, now become free flowing. They are adding, so your neutrophil count is going up. Bone marrow missing, the cells are entering rapidly. So, the first cell in any infection to respond is neutrophils, and neutrophils are the first cells to reach any infective site. These are the most motile cells, and these are the ones which will reach the first this thing. Okay. Now, why did I teach you all this? When you come to this leukocytosis now, differential. At that time, this point is going to be important. We are going to come to this point again. So, you should not be lost out over there. I'll give you the reason. Because medicine is not to be mugged up. It is to be understood. If you understand it,
Yes.
you will be able to, this thing, you can recollect it at will and do it. Mugging up,
Sure.
yeah, that's the thing. You forget it if you don't use it. Okay. So, no, what is more, जल से पतला क्या है? Water से पतला क्या है? ज्ञान, knowledge.
Okay.
Knowledge is even more thinner than water. You know, you can't hold water in your hand. The same way, the knowledge, if you don't use the knowledge, it's just going to pour out. How many of you remember your anatomy muscles? You know, if I say psoas muscles kidhar hai, you will have difficulty in knowing it because we never use that term. Once you know we are into clinical practice, we don't want flexor digitorum longus. Abhi kuch yaad aa raha hai. So something of that muscles out here. So jal se patla gyan. So you lose that. So if you know the reasoning, you remember it. Okay, so fine, we go to that. Now next we march on to eosinophils. Okay. Now, eosinophils, as I said, parasites and an allergy. Now eosinophils produce two chemicals. Now these two chemicals are important. One is histaminase. Histaminase, ASE, at the end. Okay, histaminase. And the other is aryl sulfatase, ARYL sulfatase. Now, any word ending in ASE is an enzyme. Lipase, amylase, galactase. Alright, all those are enzymes. So, these are enzymes. So, what does histaminase do? As the word suggests, it breaks down histamine. Histamine is a molecule which is associated with inflammation and which dilates the blood vessels. So eosinophils will break down this histamine and stop that inflammatory process at that point. Okay, so eosinophils in a way is an anti-inflammatory the same. Alright. And aryl sulfatase, it breaks down leukotrienes. Now leukotrienes are produced by the mast cells. Mast cells produce leukotrienes, which is to attract other cells into the tissue, where the infection is going on, where the fight is going against the thing. So leukotrienes are chemoattractants. So this again is broken down by eosinophils. So two molecules, histaminase and aryl sulfatase. Okay. Now eosinophils will increase also in some neoplasms. Asthma, okay, collagen vascular diseases, okay, and of course parasites and allergy, as I given you earlier, the most commonest. Okay.
They increase in the asthma and
Some neoplasms. Now basophils, the same granulocyte, is least abundant, and what they have is special receptors on the body, on the cell membrane. they have those receptors to which IgE, immunoglobulin IgE gets attached to basophils. So body, they have a receptor on which this IgE gets adapted, and this is the basophil. And since IgE, as you know, is associated with allergy and all hypersensitivity and all that, so this is where this IgE comes into play. Okay, now basophils release three types of chemicals. One is heparin. Okay. Second is histamine, and third is leukotrienes. Okay, so two chemicals, heparin, forget that heparin, but the other, histamine and leukotriene, both produced by basophils and neutralized by the eosinophils. Okay, so you see, when the basophils are also increased, this is also going to increase, and all that is going to come out. Other not so rare causes that you can find in basophils and goes up is thalassemia. Just to complete, not so rare causes: thalassemia, anemia of chronic disease, iron deficiency anemia, lead poisoning. If you see basophils, lead poisoning thing, child is eating paint. Alright. Lead is not. Now this completes granulocytes. In granulocytes, first we go to monocytes. They increase in, as I said, they increase in chronic inflammations or infection. They stay in the circulation for about 2 to 3 days. 2 to 3 days. Their lifespan in the blood vessel is just 2 to 3 days. After which they migrate into the tissues where they are called macrophages. And as a macrophage, they can live for years together. They have a very long lifespan, macrophages. Okay.
You just go over monocytes.
Yeah, monocytes.
Lifespan 2 to 3 days, but if it comes
No. Monocytes, they will survive over here for 2 to 3 days, after which they migrate into tissues and survive for years together. Okay, as macrophages.
But if there is an infection?
No, they are still there, like on guard duty. You are building a security guard is there, even if nobody is entering, he is still standing there.
But the monocytes are called as macrophages only when they go to attack.
No. Once they enter the tissues, the same, they are called macrophages. Okay.
Not from the blood.
The monocytes, they are monocytes. Once they enter the same, macrophages out here. Okay. Right. Now these macrophages, when they enter the tissues, they have special names in special tissues. Supposing if they enter the CNS, so they are called microglial cells. Alright. So when they enter the same microglial cells, when they enter the alveoli of the lungs, they are called alveolar macrophages. Simple, alveolar macrophages. In the liver, they are called the kapha cells, Kupha cells or kapha cells. Okay. Then in the lymph nodes and in the same spleens, they are called sinus macrophages. Okay. In the skin, when they enter the skin, they are called Langerhans cells. And kidney, mesangial cells. And bones.
In the skin, they are called as
Langerhans cells.
In the pancreas also, you have iris of Langerhans.
Yeah, but these are Langerhans cells. Okay, and bones, osteoclasts. Okay, now in bones, osteoclasts. Why osteoclasts? The osteoclasts are the ones which are destroying the bones. You see, you have two types of cells in bone: osteoblast and osteoclast. Osteoblast is the one which lays the bones, and osteoclast is the one which destroys, which takes away the bone. The calcium out from the same, destroys the bone. The same. What happens is the remodeling of the bones and all that is because of balance of blastic and plastic activity of the osteoclasts. So osteoclasts, because they are the ones which are devouring, they are from these macrophages, they are from the monocytes. Alright, and once I told you also, because neutrophils, just couple of hours they go into the cells and they live for 2 or 3 days and then they die. So our tissues are not a graveyard for
All the cells.
cells. So this macrophage will pick up this and they eat these cells, neutrophils, all the scavengers. These are the scavenger cells, which will the same. So what are the functions of macrophages? First thing I just explained, phagocytosis of what? Of
Any
bacteria.
any
Including
bacteria, any bacteria, any parasites, injured cells which have got injured in the attack, plus the old RBCs, platelets, WBCs, all those, old RBCs. Why RBCs? Why RBCs? How do you see RBCs in the tissues that this macrophage?
They change their shapes.
No. The graveyard of RBC is spleen.
Spleen.
And I said this macrophages
Can be present in the spleen also.
are present in large quantities in the spleen. So that's a graveyard. So that is where they'll engulf the RBC, old senesced RBC, and break it down. Break the heme component out and porphyrin component out. Biliverdin will come out, bilirubin will come up. The heme, the iron will be processed, like I said last time. So this is the way it goes. Okay. Then another function of this monocyte is they are called antigen presenting cells, APC.
Oh, for the antibody creation.
Yeah, what happens is this will process those foreign thing in such a way that the antigenic surfaces are presented to the lymphocytes for them to take action. Okay, now look, this is the point at which you have to attack. This is your attack point. Your attack point, not anything else. So this is an antigen presenting cell. Correct? Okay, lymphocytes again, 3 types. One, you remember? Natural killer cell, which is from the innate or natural immunity. Okay, natural killer cell. The other 2 are the beta cells, B cells and the T cells. Okay, B cells functions antibodies. T cell is the T cell mediated cellular immunity part. Okay. Now that we have got an idea of all this, we now go into this topic, the top, where we will now be able to understand what is happening in this leukocytosis leukopenia, because we know this now. Okay, now we come to leukocytosis, the most commonest that we are going to encounter, because this is the infective part which is going to come after the same. Now, what do I do? Leukocytosis is anything greater than 11,000. Right. Now,
You have 20 minutes in the time.
how much time? We started at about 2:45. So how much time is it now? 3:15. No, I should have completed leukocytosis by now. Okay, but then okay, fine. We'll do leukocytosis. Okay. Now, okay, I'll take this right now over here itself. Okay. We have a 4,000, 11,000 range. Anything less than 4 is neutropenia. Leukopenia, and this is leukocytosis. Okay. Now, very often patients come and tell you, they've gone to another doctor. They'll come to you, report लाए, report तो किया था वो, लेकिन डॉक्टर ने बोला नॉर्मल था, So you assume it's normal and you let it go at that point of time. और they'll say कि 2 बार हमने रिपोर्ट निकाला but normal था दोनों रिपोर्ट. Now you have to turn into a power user of this CBC. Even a normal report has a lot to tell you, whereas one single report is a snapshot of that patient's condition at that point of time. But now if you have 2 reports, you have a range from this day to this day, or from this hour to this hour. Now you know what is happening in his body. It's the failure to look at this earlier report and concentrating only on the new report. That's where we lose so much vital clues, you know. So supposing if a patient has taken out his reports, his first report says 7,000. Leukocytes says 7,000. It's normal. Doctor ने बोला तेरा report normal आया है. He still has fever. 2 days later again doctor says नहीं यार report निकालेंगे अभी तेरा वापस देखते हैं. It comes to 9. Now this is still normal.
But it is increasing.
But the doctors and the patient has not got this old report. Doctor doesn't know it unless he has made mention in his reports, in his notes. So now 9 again is normal. तभी क्या है report था? Doctor साहब आपने normal बोला था. Now you say again normal. But here you missed a vital clue that it is rising now. From 4 to 7 to 9, it is normal, but it is a rising trend. So what is happening is you look at the trends. When you're going to get, if you get an acute case, you're not going to get this trends. But then if you get a case, you know, he has gone to 2 doctors, 3 doctors, or 1 doctor has come to you now frustrated and wants this thing, and you look at this trends. This is going to help you. Now you know 7, 9, this is going to go up. So there's some pathogenic infection, some infection occurring, which is now pushing the count up. You are now on your guard, even though these 2 reports are normal.
So
this is the
how
trend.
often should you repeat?
I'll come to that repeating part. But in case you have this, become a power user. Don't neglect the first report. Use those and see what is the changes that are occurring and interpret it accordingly. Alright. Now supposing if patient says that, nee, forget that, I'll take it later. This part I'll take it later. Okay. So you have this thing. Now, once you have this increased count, it has gone beyond 11. Now you look at this, which of the cell lines has increased, which of this percentage has increased now? Huh? So you will see what obviously has caused this thing, and the thing most often is the neutrophils which has increased. So you get this thing, so you have a clue that is a pathogenic or this thing, a septic pathogenic bacterial infection that you are probably dealing with. Okay. Now most of the labs, I do not know most, I know some labs or maybe the thing will say that banded neutrophils are seen. Banding of the neutrophils is seen. So if you have leukocytosis, neutrophilia and banding, you're definitely on sure grounds that this is a pathogenic infection. You are now going to consider this thing, where is the focus of that infection, and you have to give antibiotics out of it. Okay, because the band cells will increase. Band cells are nothing but neutrophils again. Alright. So when you say bandemia or band cells proportion has increased, you have other thing. Now we'll give you a diagnostic to other thing. That clue the thing. Now, what are the causes of leukocytosis? We'll discuss only 4 common the thing. Infection, steroids, leukemias, and 4th, a catastrophic event. Just 4, yeah, catastrophic event. I'll tell you what. Catastrophic like the myocardial infarct, pulmonary embolism, and all this. So in 4 cases, you will see most common. Forget the other causes. This is what you're going to encounter 19% or 95% of the times in our practice. We'll stick to that. First one is the same infection. Second is steroids. Third is leukemias. Leukemias naturally, leukemia में WBC cell counts are going to go up into 40, 50, 60 lakhs के ऊपर जाने वाला है. Okay, now steroids also cause leukocytosis. Patients who are on steroids, who are the patients on steroids? Most of the same times are those are
Skin
Skin,
and bone,
yeah.
chronic pain,
not
asthma.
asthma nowadays. More of them they are going on to the but autoimmune disease parts. Okay.
Yeah.
All right. Those rheumatoid arthritis patients, ankylosing the same, psoriasis patient, and all those patients are there on steroids. They are the same. Bell's palsy patient on a steroid. You know, you have a Bell's palsy patient. You are put on steroids, and you do a CBC. 5 days later, patient is complaining, and you find the same leukocytosis going up. You pause. Now, how do you differentiate between the leukocytosis of a pathogenic infection and steroids? Both cause the counts to go up. How do you differentiate the same? Now, to differentiate that in short, what happens is, steroids, the WBC counts increase because of 3 reasons. One is demargination. Demargination is these cells which are out over here enter into this circulation. And I told you that this is the one which is used in the WBC count. So this are substantial. So this will all enter into the circulation and this will boost up the WBC count. This accounts for 60% of that WBC count because of steroids. Correct? Demargination. It's called demargination. So the marginated leukocytes now enter into the circulation because of the steroids. Okay. Another thing is that steroids do not allow the WBCs to go out into the tissues. You know, like I said, neutrophils, couple of hours and it feels very homesick. You know. This is not his environment. He wants to go home to his tissue environment. So it doesn't allow it to go. So this contributes about 30% to the same. And 10% contribution comes from the band cell release from the bone marrow. Alright. So now how do you differentiate between a steroid leukocytosis and an infective leukocytosis? You have a patient which is the same, on steroids for his rheumatic arthritis problem, and he's come with fever. Now you are in a dilemma. He's got leukocytosis out over there. How do you differentiate between the two? You may or may not be able to do it, but what I told you is that the band cells of steroid, in steroids, band cells only contribute 10% of the leukocytosis, whereas in infection the band cells are of large quantity. So if you really get bandemia, increase of bands in the cells, it is more of infective, goes in favor of infection rather than steroids. Okay. Another thing is that in infection, because we are talking of infection and pathogenic this thing, if the counts are going up and neutrophils are very high, 80%, 85%, 90%, you can be sure that this is infection somewhere the same. Even though the patient is taking steroid, you cannot explain away that this, cannot ignore that the same. And the third, the thing, what you call as and what will happen in steroids? What will happen in steroids is that this, because the patient is normal, this will remain in the normal. You get the differential counts normal. Whereas in infection, this is going to go up. Steroids, only steroids, you will have the same percentage, nothing great in this differential count. They are all normal, in the normal range. Okay. So that is that for that. Then leukemia is again self-explanatory: acute myeloid leukemia, chronic myeloid leukemia, ALL, CLL, AML, CML, all that. Okay, in the same. And last one is catastrophic, like a myocardial infarction, pulmonary embolism, and the same, a major surgery. All this, which, why do they cause that?
Because of the injury.
They want to
injury, heal, and another thing, the stress in the body is too much. So you know, steroids, again steroids cause leukocytosis. So again, once the stress is there, steroid levels go up. You want to get all this thing. So this is, you see, but this is going to be transient phenomena. And believe me, upon heart attack of patients, we are not going to see now OBDs. Neither are we going to see pulmonary embolism. You have to push them out. So this goes off. Okay, as a side, this thing that a cold shower can increase the WBC count. Yeah. So if we had a very cold shower and then after that we go and give the blood, CBC, WBC count will be marginally increased.
Okay.
Okay, marginally increased. Now,
So thermal reactability is there with them.
I don't know, but this is a what do you call it?
Cold shower, how cold?
I don't know that also. I even don't know that. But this is
No, is it chill and cold?
I don't know.
Chill
But then
chill. Like you.
I got it from a good source, and
No,
therefore added it.
nowadays, the celebrities are going for that Antarctica water bath.
Yeah. Yes, the same. Yeah, the same. So that's the thing that can increase your temporarily increase your WBC count. Okay, so that completes leukocytosis. Now we come to leukopenia. Now leukopenia, anything less than 4,000. Again, same the same. This is a very short topic. Okay, so most of the times in leukopenia, you want to concentrate on this neutropenia. You want to get this neutropenia, and here you want to calculate one value which is called absolute neutrophil count, ANC. Most of the labs give you this absolute counts also, and believe me, don't stop looking at the absolute counts because they also convey a lot of information. I'll be touching on that information, but they convey a lot of information. Do extract information from that. It's like a Sherlock Holmes, we have to go through that. Okay, so the same. So we have the absolute neutrophil counts. How do you calculate? Even if you do not given the absolute neutrophil counts, what you do is, if the count is, say leukocyte count is 2,000, alright, and this neutrophil count is 25. So multiply it by 25, divide by 100, because it's 25%. So 1/4 of that will give you 500. So absolute neutrophil count is 500. Alright. It's simple, it's just mathematics, just WBC count into the neutrophil percentage divided by 100, and you got the absolute neutrophil count. Okay. Now if this absolute neutrophil count, 3 stages, between 1,500 and 1,000 is mild. Between 1,000 and 500 is moderate, and less than 500 is severe neutropenia. Correct? What are the causes of leukopenia? Rapidly. Sepsis. One again, sepsis. Sepsis common again to both leukocytosis and leukopenia.
In sepsis, you should go up.
Yeah, exactly. Now, if a patient has got sepsis, he's got his in septicemia, and you see this counts, a high count or a low count. Now, what it also has a prognostic significance, because if the counts are high, leukocytosis with septicemia, the mortality is about 19%.
Oh.
Yeah, but the thing, septicemia with leukopenia and neutropenia, the thing, mortality rises to 33%.
Oh.
So you see the thing is very high mortality. So you are your prognosis just changes. So if a patient of yours, this thing is going for leukocytosis or leukopenia, don't be too happy about that. This thing is really going bad. The prognosis is going bad.
But the body is given a criteria or something.
I don't know. I can't. The mechanism and all that stuff. Maybe, probably that's the way it is. But then,
Because technically the antibiotics are going up, and you find the count actually going down, you may think of it as a good sign.
yeah. But then if your going to leukopenia means you are really in a soup now.
Yeah.
You are really in a soup. Okay, so sepsis is one cause. Second cause is liver diseases, cirrhosis and NASH, non-alcoholic steatohepatitis. Okay. Dr. Prakash, we should have a lecture on this liver also, because nowadays you're getting this topics on liver, USG, grade 1 fatty liver, grade 2 fatty liver.
both alcoholic, non-alcoholic.
Yeah, and you don't know what to do, grade 1 उड़ा नहीं सकते हम लोग कभी grade 1 fatty liver देखा, you can't say anything कुछ नहीं,
So many people are coming with
So
fatty
many,
liver.
even non-alcoholic.
No, okay. So when you're seeing all those, you need to be careful about it and understand. So what to do with that? Separate topic. It's a big topic by itself. Yeah, hence listen. So you should have that topic. Keep it at the back of your mind. The liver disease. Why should it go up in liver disease? Why should the counts go down in liver disease? One thing, because portal hypertension, the spleen is enlarged. Because the portal hypertension is there, liver में pressure है, portal hypertension is there, the blood gets sequestrated in the spleen. Spleen becomes enlarged. Now what happens is that spleen becomes a reservoir of lot of WBCs, RBCs and platelets. So that's why you see in liver disease this count going down. So leukopenia in liver disease. Okay. It's just nothing but the redistribution of the WBCs into the splanchnic circulation, and some medications. Now the third important cause is medication. Three causes: sepsis, liver disease, and medication. Medications. Now, if you're seeing this in this range, neutropenia, this is mostly because of immunosuppressions, immunosuppression medicines or chemo or immunomodulators. This is the range where you will get this thing. Most of the time, it can even go here, because if that person has leukemia and that person, the same chemo is wiping out all the WBCs, can fall even here also. But most of the times in chemos, other chemos, we find it in this thing. Now, where there is a drug induced idiosyncratic reaction, this is where the drug range will lie, between 500 and 1000. So if you're getting somewhere out to here, you may not want to consider drug. You may think more of other immunomodulators and all that. But anyway, you will have the patient history in front of you, so you have what to expect from that. But drugs here, this is the point at which you start searching for the drugs. Most of the drugs like NSAIDs, drugs used in thyroids, ACE inhibitors, antibiotics like macrolides. Macrolides are like azithromycin. Okay, erythromycin, which should now be stopped prescribing, and vancomycin, cephalosporins, diuretics, and all are the same causes. Now, this three. Now, completing the list, fourth is viral infection. Okay, viral infections may counts will go down, like viral like dengue, HIV, most commonest. Okay. Some cancers which spread to the bone marrow. Autoimmune disorders also can by themselves bring the count down, and some nutritional like B12, folate, and copper deficiencies, all that can be sent. Okay. Fine. Okay, now we go straight to the febrile part of the second talk, which is I'll be covering up dengue in detail. Along with that, we'll cover the differential diagnosis of other diseases so that you become proficient in prognostic or diagnosing what it could be before you order the investigations. So before we go to dengue, one vital concept that I want to put forward to you is that okay, before we go to dengue proper, just one small concept which I want to clear so that dengue explanation becomes easier, is that we have fluid compartments in our body, which is intracellular fluid, which is found in the cells. Now the extracellular fluid compartment is one in the tissues and one in the blood vessels. Now there is a constant flow of nutrients and materials between the tissue and the blood vessels, and keeps these compartments in a normal volume, size, and in a physiological state. Now what actually drives all these things are the blood vessels. If you see the electrolytes of the crystalloids like sodium, potassium, chlorides and all that, they are the ones which will push the fluid out of the blood vessel. Electrolytes will push the fluids out of the blood vessels. If you remember our experiments in school, parchment membrane we had, and we used to put in
resins and the potatoes
and salt and all that inside that the same parchment membrane, and then dip it in the beaker, and then once beaker may say put only that yes, it is salty, it is sugary. So that parchment, so these are the electrolytes which give a pressure outward, which forces the fluids outward inside. Whereas the proteins, the albumin, globulins and all that will tend to draw the fluid inside. Now it's a balance of this two which keeps this extracellular fluids and the blood vessels volumes separate and in a physiological state. Okay. So remember this one principle, that is the protein which is going to bring the fluids back into the blood vessels, whereas the electrolytes push the fluids out of the vessel. Simple some school vessel. Now dengue, we come to dengue, which is one disease which can increase your practice a lot. If you know how to handle dengue, your practice will increase. Patients will tell you that you are the Sai Baba. अरे वो पेशेंट उसके पास जाओ, वो साई बाबा था, उसने मेरे को बोला था मेरा प्लेटलेट काउंट कल बढ़ेगा, दूसरे दिन किया तो बराबर बढ़ के आया, उसके पास कुछ मैजिक पावर है, साई बाबा है, उसके पास जाओ. So this is how the word of mouth spread will occur. Your practice will increase because you become proficient in dengue. And it's very simple, though it has its own mortality figures and statistics on which you have to be very careful, but if you are very vigilant, you can sail through and you can bring the patient safely through the whole thing. Okay, now clinical features, high fever at onset. Onset begins with high fever. So patient is going to come to you on day 1 or probably the next day is going to come to you high fever, body ache, retroorbital pain behind the eyes. Okay, there's myalgia, lot of muscle pains, less of arthralgia, less of joint pain, but more of muscle pains, and a rash. These are the typical thing what you're going to see in a dengue. Alright, now contrast it with other diseases, like if you want to say influenza, flu, your respiratory component, cold, rhinorrhea is going to come in, then sore throat, then cough is going to come in. So those will point towards a respiratory virus pathology. This is a generalized constitutional symptom which you're going to face the same. Now, again COVID, again a virus illness, same like dengue, but the same. COVID you have respiratory symptoms, the same. And another differential is enteric fever or typhoid. Now typhoid will not come on the first day or second day to you because it's a low grade fever to begin. This is a abrupt onset high grade fever. This is a low grade fever, so it takes a couple of days for you to come to your this thing. He's going to try out paracetamol and come to you. So that is one way in which we can clinically say. Another thing is that if the patient has come deep into the fever, remember that the dengue fever is just up till 7 days. If you're seeing fever on the 9th or 10th day, this is not a dengue fever. Forget dengue about it. We don't go into that. Now, clinical part. Now, diagnostic part of it. First 4 days, first 4 or 5 days, the diagnostic test would be NSI, NS1, sorry. Okay, it's an antigen test, non-specific, and NS1 test. Now, in this, it becomes a high chance of becoming positive from the second day onwards. If you investigate on the first day, you may not get it positive. NS1 will definitely come positive from the second to the 5th day. Now, most of the labs do the card test, which are not so sensitive, so they may not pick it up. So what you do is you tell the lab to do the same ELISA test. Order ELISA test, which is more sensitive, and it will pick up that NS1. So it will save you a lot of headache. It is costly, but it will save you that headache. It will save you that headache of what diagnosis you are going to give to the patient. Okay, so you will get that the same. Now from the 5th day onwards, the antibody production starts. Now the antibody which is produced on the 5th day is IgM. Okay. So on the 5th day, you order IgM test. Save money for the adult patients. Don't order IgG also. IgG is useless because it tells you of the previous past infection, which we are not interested. This is more important in the pediatric age population, IgG, because in pediatric age population, the second dengue is really worse. So you have to be very careful. You may want to admit the pediatric child if you're not confident about the same. You may on the safer side may want to admit. So IgG becomes important in a pediatric age, whereas in adults doing IgG and wasting the money is no point. Okay, so you do IgM for that and it comes positive from the 5th day onwards, and that will give you the diagnosis. Usually by about 10 days, dengue is all over. So in that days you get the IgM positive. Around the 7th, 8th day, IgG will start increasing, but we are not interested in the IgG component. The IgM will give you the true diagnosis, which is the acute disease, the site. Now we come down to the CBC picture. Okay, we are now diagnosed it. Now the most important is CBC picture, which, see, master it. You have to be a master of this CBC pictures. Now, something like about 10-12 years ago, we had a huge epidemic of dengue fever, and we were all at sea, nothing, not knowing what to do. So all that I did was started collecting all the CBCs, the patients, especially CBC of the patients which got admitted. So I had a CBC, track the CBC reports, the same serial one video the other. I told you a trend, seeing the trend. So put them together. Once the patients are admitted, the CBC is being done twice a day, thrice a day. So you get a lot of CBC reports, you get the trend, you get any follow. And what I have found and what other doctors have found is what I am now going to tell you, and which is given in many of the books also. So now follow this to become a master of dengue. Initial first or second day, what happens is the WBC count goes southwards. It becomes low. Leukopenia occurs. Okay. So this is the same. So once you see leukopenia, your bati is on now. You're dealing with a viral infection, but you do not know which. But probably your clinical features are giving us the same sign, retro or viral and all that. Now another clinical feature that I forgot to the same is that chikungunya. Chikungunya will have more of arthralgia than myalgia. So that will differentiate, that will give you a differentiating feature from dengue fever. So we have covered. Then another thing that I forgot is malaria. Now malaria, again, one feature that will stand out is headache, which will alert you towards the thing. Another thing is that in between the spikes, the patient is normal. So this is a clinical feature which is going to alert. So we have got of malaria, chikungunya, dengue, respiratory, this thing, COVID, sub ho gaya. Anything else we are leaving out? We want to remember? We can think of. Enteric also we covered up. I said that low step ladder fashion. First day will be just marginal rise, 98, 99. Second day you might see a little bit above that. Third day will be 100 and beyond. Fourth day will be 101, 102, and the patient is on your doorstep. Doctor kuch karo. So that is how this thing is going to give you the thing. So now this is the thing. So WBC count for 2 days. Now you want to be the Sai Baba. So you tell the patient, patient is worried, WBC count नीचे गया 3000 के, WBC 3, अभी मेरे को इन्फेक्शन होगा, क्या होगा, एडमिट करो, डॉक्टर ने इम्यूनिटी नहीं है, कुछ नहीं है, बट यू आर द साई बाबा. सो यू विल से नो, देख बच्चा ये WBC काउंट कल या परसों तक ऊपर आ जाएगा, और जैसे ही ये ऊपर आने लगेगा ना, तेरा प्लेटलेट काउंट नीचे आने वाला है. बिकॉज वंस यू से ऊपर आने वाला, ही बिकम्स वेरी हैप्पी. Bring him down a few steps down and say platelet count नीचे आने वाला है. So he becomes worried again. So he's going to come back again to you. So but then now you are predicted for him. So next day when you do a WBC, CBC this thing, and he sees that this is happening, now his confidence level in you is rising. He says yes, ये डॉक्टर को कुछ तो मालूम है. अभी प्लेटलेट काउंट डॉक्टर साहब, see by about second or third day platelet count is falling, but is still within the normal. The same platelet is between 1.5 4.5 is still normal, so it's not going to the same fall the same. By about the third or fourth day it is going to drop. You're telling the patient it is going to drop, so you're winning the confidence of the patient. Platelets will drop. Now the WBC count is going to go up. Alright, WBC count is going up as soon as the platelets are going down. So your the signs are coming true now. Prediction coming. Now you're on the 4th or 5th day with the platelet counts down. Now what happens to the platelet counts? The platelet counts will keep falling till the fever is there. And max the fever goes up till the 7th day. So you can expect the platelet counts will fall till the 7th day. After the fever defervescence occurs, the fever has subsided. For 2 more days, the platelet count will still fall. So remember this fact that you're going to have a fall for 2 more days after the fever goes away. So if the patient is on the 5th day and fever is almost subsiding, अभी मेरे को अच्छा लग रहा है, बुखार इतना नहीं आ रहा है, and the count is 50,000, you're still on safe grounds. 50, next 2 days it will still fall, but after that it's going to rise. You're still on safe ground, so you can still keep the patient with you and treat him, because you're going to predict if तेरा count कल भी नीचे जाने वाला है.
So they're doing the report every day?
Yeah, you do the report every day.
Even twice in a day.
Twice in a day?
Twice in a day.
हाँ जी, I'm coming to it. So कल भी तेरा नीचे गिरने वाला है, लेकिन परसों के दिन तेरा ऊपर आएगा. He'll do the reports, he'll get it to you. He's still a worried man. ये बोला ये साई बाबा कुछ बराबर प्रेडिक्शन निकलता है कि नहीं मालूम नहीं है, but still a worried man. But after that, next day he does, and the platelet count is stabilized or is coming up. He's now happy. Now he has got full confidence in you. He has got his confidence is restored in you. Now you see how much you have gained the confidence of the patient. How well you have come across to the patient. You are not panicked. Remember that, our actions, our speech, tonality, tone of the voice, and the way we speak, even a slight microsecond of hesitation in our reply is caught up by the patient. Patient will understand that and will realize it, sense it, and he will start losing confidence in you. But if you are in a confident way, you tell this is where he gets confidence in you. नहीं ये तो ऐसा ही होगा, अभी देखो कल देखे कल करेंगे, कल देखते क्या होता है, फिर बाद में सोचेंगे. नो, दैट पेशेंट इसलिए डॉक्टर को खुद कुछ मांग नहीं है, नॉट दिस बट द मोमेंट यू से यू नो दिस इज द पेशेंट, यस यू आर लाइक अ गवर्नमेंट टू हिम, and it comes out that way, you one is winning his confidence over, so that way, okay. Now this is on CBC. Now CBC you will see two more things, hemoglobin and paxil volume. Both
In the same venue.
in the same CBC, the same. When you're seeing this, what all I'm on the investigation part of the dengue fever right now. Once we have proven that it's a dengue, the same, like using NS1 or IgM, and we have proven it. Now we are doing the CBC, this thing coming, how to handle the CBC part of it. We have completed the platelet part, which is the most famous part, which the patients are most worried about. We completed even the leukopenia part of it, which is a minor missing. Patients are not worried because in a day or two the WBC count goes up. So we have finished with that. Now we are coming to HB and PCV. This thing is the danger point is the HB hemoglobin and the paxil volume increasing. That is a danger red flag to be monitored for that. That's an indication of extravasation of capillary. So that is what we are going to do that. Okay, besides this, what other investigations would you do? You would like to do SGOT and SGPT. Okay, both will be raised, and they may be raised well above 1,000 this thing. Okay, now why should SGOT be raised? SGOT is more of a muscular component. So because you have myalgia and all that, SGOT will go up. SGPT is because of the liver, the same. So you are alert at Papa now. The liver is also getting involved. You are on your alert. Okay, and you may want to do your creatinine, BUN, and blood sugars, right, to complete the investigation test. One other this thing is sonography. You will not do sonography immediately, but you will do it only when you expect that there is extravasation or a capillary leak. Now what is extravasation and capillary leak? This is the point at which you have to be really be afraid of. This occurs on the 5th day.
Yes, why the sonography for the extravasation?
Yeah, I'll come to that, why you want to do that. So on the 5th day, what happens is IgM starts come into play because your immune system is now coming into play. It's come out on the field group PAT. Batting chalu kar diya uska. So it is hitting 4s and 6s. In that, there's an antibody mediated reaction in which the capillary walls get affected and the capillaries start to ooze out, or the extravasation of the fluid occurs from the vascular compartment into the intercellular space. Okay, both are ECF, extracellular compartment, but from the vascular compartment of the ECF it is going into the intercellular spaces. The fluid leaks out. So when the fluid is leaking out, last time when I had taught you, the paxil volume is the same when you centrifuge it and you get the RBC and the same. So the fluid component is becoming less. So the RBC, paxil volume, hematocrit will become up, will go up. Alright? And because the hemoglobin, paxil volume is going up, your hemoglobin is also going up. I told you, remember that 45% is normal, uska 1/3 is the hemoglobin. So that hemoglobin also follows the same pattern. Hemoglobin will also will show rise. This is a trend that you are now going towards extravasation. Okay. This is where you will be listening. Now, yeah.
I want to leave.
Okay.
Why does the extravasation create problem?
Yeah. Extravasation means the liquid fluid leaks out into the extracellular fluids. Now, your paxil volume is going up because your fluids have left the blood vessels. You develop signs of No. Dehydration. You are clinically dehydrated and all that stuff. So now you are in dehydrated phase and you want to push in fluids. Okay, because you're dehydrated. One thing that I forgot to saying is that even dengue is another feature is nausea and vomiting. Again, important features nausea and vomiting. Nausea maybe not, but if you have nausea and vomiting then starts occurring, for which you don't have a cause, then you are the same probability of extravasation going out over here, right? Because of the capillary leak.
The nausea.
Yeah. So that is the capillary leak. The same. Okay. So what happens with the capillary leak is the fluid goes out of the vascular compartment into the extracellular, the same intercellular spaces. Wait, edema would be the last to develop. The very first places where you go in is the peritoneal cavity, peritoneum, the peritoneal cavity, ascites, some amount of the same pleural effusion. Okay, yeah, some around the gallbladder. Okay, some fluid collected around the space around the gallbladder. Okay. Then some in the lungs parenchyma. Now you know lungs parenchyma mein gaya fluids. You're heading towards. Now you're heading towards ARDS, pulmonary edema, and all those pictures. Okay. Yeah. But wait, now this is at the initial stage which you're going to get this. Now how do you actually clinically suspect extravasation has occurred? The most commonest thing that we expect that on examination that you have to do is check the BP every day and note it down. Note down the BP every day, note it down, and if the pulse pressure falls, pulse pressure falls to 20 or below that, it is extravasation. It's a sign of impending or rather a shock syndrome. Okay. So what is pulse pressure? Pulse pressure is the difference between the systolic and diastolic. So supposing the BP is 100 by 80, so the pulse pressure is 100 minus 80, 20. Okay. Now, this is because the fluid has leaked out of the blood vessels. Extravasation. Okay. Now, we take symptom wise. How do we the same for each of the organs that I told you of? Ascites. What happens in ascites is simply make the patient lie down, palpate his abdomen. If you get tenderness somewhere in the lower part of the abdomen and all that, this means that this patient is developing ascites. Is a red flag for you.
Just tenderness.
Yeah, you develop tenderness or rebound tenderness, like rebound tenderness is like you are pressing and you suddenly let it go and the patient winces. This is the rebound tenderness of appendicitis. But when you get it in dengue, you get it all around in the lower abdomen. That is the rebound tenderness. That tells you that yes, now your peritoneum has been involved. Another thing in the abdomen you check is in the right hypochondrium, put your fingers, palpate the liver. Tell the patient to take a deep breath. Once he is taking a deep breath, he stops and he winces, because your hand has now touched the gallbladder where the fluid collection is there. That is causing him to cause pain. So that is another sign of this, that now you got this. Now another space where I said was the pleural effusion. How will you diagnose in a pleural effusion? Simple. You check the respiratory rate of the patient. How do you check the respiratory rate of the patient? If you consciously do it, he is not going to allow you to do it. Because the moment I tell you I am going to take a respiratory rate, you are going to alter it. Subconsciously you alter it. Best is when you're taking the pulse, and your eye is also on the watch, but from the corner of the eye you're seeing the abdominal movements, you know you'll get the respiratory rate. You take a little bit longer for the pulse. पेशेंट को भी अच्छा लगेगा कि डॉक्टर अच्छा ठीक चेक करता है, you know, ऐसा उन्हीं ने लगा के छोड़ नहीं दिया. So you're checking for both. So pulse. So if the respiratory rate increases, no, and then you ask the patient, you know, are you feeling dyspnea? Are you having shortness of breath? सांस उठा लगता है कि नहीं? The patient says no. This is the pure dyspnea. Oh, okay. So respiratory tachypnea. Tachypnea is increased respiratory rate without dyspnea. This you suspect now a pleural effusion. And then of course the last to appear will be the peripheral edemas and all that. Okay. So this is where at this point you would want to do a sonography. Okay. Okay, so if you get across this thing, this is the time when you want to really admit the patient, especially if the sonography shows, you know, a fluid collection around the gallbladder, you know, and a thickened gallbladder, which is called acalculous cholecystitis. At that point, you want to really admit the patient. You really want to admit the patient, and on this again you want to take a call based on what is clinically happening also, you know. The pulse pressure is not that the same, tachypnea itna nahi hai, pain and tenderness are just mild and you're not too convinced about it, but it's still there. Sonography is not conclusive now. You may want to just keep the patient on the observation. The point is that this extravasation occurs after the 5th day. So most of the time the dengue fevers, many times the dengue fevers are over by the 5th or 6th day, and so that is when the patient feels relieved. But we as doctors should be on our guard, not let our guard down, you know, because this is the most crucial time when you want to call the patient and really check him out for this extravasation, because it's going to occur from the 5th day onwards. You want to keep him under observation for 5 to 10 days. This is where you want to put him. Extravasation occurring, get into action. Right. Okay, now
what percentage of people actually have the extravasation?
I don't know. He's asking what amount of people have extravasation. I don't know that. But okay, and platelets. So now, as I said, the platelets will continue to drop, and so I had given that example of 1 lakh platelet count, you know, high fever on 5th day. I want to admit him, because you see, because his fever is still high, so this man is going to continue up till 7th day, you know, 3 more days, 5th, 6th, 7 days in which his platelet count will fall. Platelet count will fall. So 1 lakh it will rapidly fall, and then even after 7 days the fever falls down. It will fall for 2 more weeks. So your gap for you to in which is a risky period. You may want to repeat the blood platelet count next day and do it, but you rather want the patient admitted or something like that. Now, if on the 9th day or 8th day the count is 20,000, you know, you're almost through the worst phase is gone through now. You know, you ask the patient, when was the fever gone? The fever is gone. Fever is gone. Now you know that after the fever is gone, platelet count will fall for 2 more days and then it's going to rise. So if the fever is on 7th day, 8th and 9th day, 9th is the last date it is going to fall, or 10 days is going to show a rise. Why don't you admit a 20,000 count patient if everything else is going? So how do you convince the patient? How do you convince the patient that don't get admitted and this is what is going to happen? First thing is that you already become a Sai Baba by predicting all throughout on this 7-8 days. You will lay the groundwork for the confidence of the patient to be built into your medicine. If the patient is still not convinced, make him do the CBC twice a day or 3 times a day. Because at least you're giving him something to do. Then he knows the doctor is serious, doctor monitor kar raha hai. He wants to see. So second or 2 times, 3 times a day, you are the same, keep the patient occupied that way and you are trying to delay this. But why do you want to delay admission? Why do you want to take a risk? Admit him, 20,000, we think that 20,000. Now there's only the same point is that patients get admitted and then the pressure on the admitting doctor is so much to transfuse platelets, is so great. The villager is sitting on his head and all that. Doctor आपका 30,000 सारी तो उनका transfuse नहीं करना होता है. There's a lot of tremendous pressure on that, on the hospital, all around, to give platelets this time. They give platelets, but why you don't want to give platelets? One the thing is that, giving platelets means you're giving blood products. So you are introducing antigens into that person's body. Now in the future, if he wants transfusions, he's already developed antibodies, or he will be primed up for antibody development for a future transfusion. So you may have a reaction in a future transfusion. So unnecessary, why you want to give him a transfusion? Alright.
But will the hospital people be that considerate when the patient is admitted? They will not hesitate in giving a platelet transfusion.
They have to bow down here because it's a social pressure and so at our level, if we can convince the patient, we are at least avoiding that. And remember that even transfusing platelets, you're going to, and if the patient has extravasation, you're loading this system, and you are going for lung complications again. So you don't want that again. So if you can just convince the patient and do it, he'll be grateful to you and he'll spread the word around कि इसने मेरा 20,000 था तो भी मेरे को ट्रीटमेंट करके अच्छा किया. Right. Though you're not doing anything for the patient, for the 20,000, it's going to come up on its own. You take all the credit for it and go. Okay. So the same. So now supposing you get a platelet count is low and you doubt it, it is what can you do? What are the measures that you can do to recheck those? The same 3 things you can do. Either you can recheck the sample at another lab. Second thing is get the blood collected in a heparinized vial. Normally they use EDTA vials for CBC, in which clumping of platelets can occur and will give you a false low platelet count. Platelets stick to each other and give you a false blessing. So that, and the third option is to get a manual platelet count. There are 3 options that you can do and confirm your blessing, what it is to be done. So our job is to correlate the days of infection from the first symptom, his trend on the CBC. You already predicted, you already diagnosed, now you're able to say it. Now with so much of information that I have given you, you can confidently speak to them. Your confidence shows through. You can convince the patient. Alright, so listen. Now, what happens in extravasation is when the patient gets admitted, many times the patient is given normal saline or ringer lactates or whatever, any electrolytes, because this is cheapest. Alright, keep us the same IV supplementation that we can give, so this goes on. But what you're doing is, by giving the electrolytes, you see you're pushing the lipid, you're increasing the extravasation. Yeah, so this is where that thing is increasing and it's going to accelerate the fluid out. You will land up with ERDS, pulmonary edema and all that. You don't want that. This is where the mortality lies. Because of that electrolyte going and extravasation increases. So how do you, if at all you have to give IV fluids and you want to hydrate the patient or you want to do and you're not knowing where you are in the picture, the safest way out would be a colloidal solution.
Okay.
Colloidal solution which brings the fluid back again. Proteins I said, and brings it back. You can give albumin. Albumin is very costly, but you can give hemaxin, which is a less costlier alternative, but hemaxin. But will bring the fluid back, the extravasation, and it will reverse this thing, extravasation out for you. At the same time, you're giving fluids. You're safe. You're safe fluids. So okay, so covering up all this in dengue, retrooperative pain, high grade fever, nausea, then if vomiting a red flag, myalgia greater than arthralgia, first 4 or 5 days you're going to do NS1, you're going to do the ELISA test. Right? After the 5th day, the IgM will kick in and you can do the IgM test for that. Now in one word, in pediatric groups you would like to do IgG because a past infection, if the child has suffered from infection earlier, the second attack of dengue is really worst and you want to be doubly sure. So you may not want to treat that child, you may want to refer to a pediatrician if you are not confident enough of doing that. Small child, refer कर दो, IgM positive आया, refer कर दो 4-5 साल below the same, want to remember the same. So the same. And so when will you give blood transfusion? Then wait. First we have the NS1 dengue, then we go to the IgM. Then I told you about the extravasation. No, then we went on to the CBC part where I said you will get the WBC coming down on the day 1, day 2, and on day 2, day 3 the platelets come down, WBCs are going up. Platelets will fall till the fever and 2 days beyond that. After that they will rise. Fever up till 7 days. So your platelet count maximum fall is up till the 9th day. That is there. Along with that you keep an eye on the hemoglobin and fat cell volume. Next you will do is, the SGOT, SGPT, the thing to see the liver involvement and BUN, serum creatinine and blood sugars, clinical situation wise, and sonography as and when the extravasation occurs. Like I told you, if the extravasation is occurred in the abdomen, the thing, you are going to palpate the abdomen, see the tenderness, rebound tenderness, the catching the breath as the gallbladder touches the fingers, that tachypnea, increased respiratory rate, but no dyspnea. Patient is not feeling breathless. You ask the patient, दम लग रहा है या सांस का उठाव लग रहा है? He says no. So tachypnea without dyspnea, again you're the same pleural effusion, pulse, BP, pulse pressure, again that extravasation. Now you want to do a sonography, take a call, admit patient. Per se, the same low platelet count doesn't become an indication for admission. It is this extravasation which becomes the same indication also. When will you transfuse? You will transfuse when a wet bleeding occurs. Wet bleeding, yeah. Wet bleeding occurs at any count that will occur. A wet bleeding is a bleeding through the nose, in your urinary tract, in your stools. Okay, those are wet bleedings. Under the skin that you see petechiae, those are dry. That's called dry bleeding. That's okay, fine. And of course, you want to take the transfusion in one the same because you want to avoid because of future problems. transfusions, and second the thing is the lung injury that can occur. Now, yeah, one more thing that can actually add to your aura of being a Sai Baba is the rash. Rash is another peculiar feature which you will not find in COVID, which you will not find in other diseases, but it occurs in dengue. Now, this rash is non-pruritic, but believe me, once the fever starts coming down, the effervescence is occurring, the rash starts itching, and it itches so badly that you can give the best of antihistaminics. No relief. You can give moisturizing lotions, you can give Galadriel, you can give anything. No relief. The itching occurs. Mostly the palms and soles and all those itching, bad itching. Now at this point what you can see is if the patient is having rash, you can prognosticate, ये rash बहुत खुजली करने वाला है, जिस दिन तेरा बुखार उतरेगा एक खुजली आने वाली है तेरे को. So again you are winning the confidence of the patient that this doctor knows, and once he gets the rash, then you tell him, you have to bear this rash for 2 days. After 2 days, you will be alright, irrespective of any medicines you take or you don't take. I'll give you medicines. If you get good, otherwise, but you have to bear it for 2 days. So you are missing. So with so much of prediction possible in a dengue, has so much of management possible. This is one thing which will give you real satisfaction, will give you patience, make the patient happy, and will give word of mouth publicity. उसके पास जाओ, वो 10,000 के पर भी मेरा ट्रीटमेंट करके दिया था, मेरे को हॉस्पिटल नहीं देता था, उसने मेरा अच्छा करके दिया. So that is dengue. A few words on enteric. I asked that poll question yesterday, what you want to do. Now, step ladder pattern is there, but diagnosis wise, the only way you can diagnose Pakka is by blood culture. Why not Vidal? Because Vidal comes positive in n number of cases. The specificity and sensitivity is around 50%. So even if you don't have typhoid, it's going to come positive. So should you stop doing Vidal? Yes, you should stop doing Vidal, because it's such a non-specific, non-sensitive test that once you get it positive, the patient's attention is gone towards that Vidal typhoid hua hai mujhe. The doctor's attention goes towards typhoid, and you start treating typhoid, ignoring the underlying process, because you are not aware that the Vidal is a false positive Vidal. Therefore, the Vidal has outlived its importance and should be given a burial and tata bye-bye to it. Same thing for typhi IgG, IgM, typhi-dot, IgG, IgM. Again, it has its own specificity, sensitivity, tolerance and all that. So the thing is a blood culture done in the first 7 days. Provided if you're not given any antibiotics, is the best. If you're given antibiotics, still do it. Who knows, you might pick up salmonella on this thing in the first 7 days. Because it's a step ladder type this thing, there's a very slowly rising fever. So you have enough time to do that blood culture and get that report out. That's for enteric fever. Now, last part, thrombocytopenia. Thrombocytopenia is platelets. Platelets normal count is between 1,50,000 to 4,50,000. 1.5 to 4.5. 0.5. Alright, so anything less than 1.5 is thrombocytopenia. 2 reasons. One is failure of production, failure of survival of the platelets. One reason when you can have thrombocytopenia, without thrombocytopenia, the thing is in liver disease, again, which I said, as because the liver disease, portal hypertension, liver and the spleen gets increases in size, the splanchnic circulation is large, and the platelets gets sequestrated in the splanchnic circulation, and therefore in the general circulation the platelet count will be less in liver diseases. Now, thrombocytopenia can be either asymptomatic or symptomatic. Asymptomatic, only one variety, idiopathic thrombocytopenic purpura, ITP. We'll leave it at that. We are not going to handle that. If it does come across, we will refer. So I will not go into those details. Other the thing is, when they are drug induced, is like infections, again bacterial, septic, disseminated intravascular coagulation, DIC, viral, dengue, rubella, mumps, hepatitis C. Antibiotics themselves can cause it. Heparin can, chemotherapy, all that can cause the same. Alcohol causes thrombocytopenia by two mechanisms. One, it is directly toxic to the bone marrow, so the production goes down. The alcohol, the bone marrow, so the production goes down. And second, cirrhosis of liver, and again splanchnic circulation. Okay, so that's where they get sequestrated. Then other conditions like malignancy or bone marrow disease, or where the same malignancy has infiltrated metastasis into the bone marrow. That is the same. Okay. So now one last chart before we wind up for the day. This is the platelets. That is, I said 1.5 to 4.5 is the normal range. So this would become 1. So it's less. At 1 lakh platelets, you can do surgery of the brain and eye. It's possible to do. At a platelet count of 80, epidural anesthesia can be given. At a platelet count of 50, most of the surgeries can be done. Yeah, most of the surgeries we can do it. Most of the surgeries. LSCS 80,000. You want a cesarean section, a platelet count of 80,000 is sufficient to do LSCS. 50 for most of the surgeries. 40, you may be able to do a lumbar puncture without the hemat malignancy. There is no hematological malignancy like lymphoid or the same myeloplastic leukemia and all those. So at 40 you can do a lumbar. At 30 you can do a bronchoalveolar lavage. You can put in. 20 you can do a diagnostic endoscopy also. At 20,000 count of platelets, a diagnostic endoscopy is allowed. Okay. And at a count of 10,000 also, you would like to do a lumbar puncture if it is a hematological malignancy, to confirm if the malignancy has spread to the CNS or not. Alright? So even at 10,000 you can get away with a lumbar puncture with this platelet count. Clinically, a primary spontaneous bleeding can occur even with 100. Bleeding can occur even with count of 100. Hemat malignancy at the count of 50. Fever and septic conditions will give count of 30. Okay. Afebrile conditions will give count of 10. Go down to 10. Clinical presentation. This is how low they can go. And what you can do. this finished. Now, 2 words on that trend part here. Okay. I told you about the trend, 4 and 11. Now again, if you have something like, what is happening is, you have a picture over here which shows 8. Now if I can give you one example,
This is a leukocyte count.
leukocyte count, yeah, leukocyte. If I can give you an example of plane which is taking off. Plane which is taking off is at an angle. Its flaps are down. Its speed is slow. Alright. And the wheels are still down. Wheels are still seen. And it is in a takeoff position. So now you know that this plane is in takeoff position. Compare and contrast it with that, there is a flight coming down on another parallel runway. This both are coming. Now this flight also has its flaps down to break the speed. The speed is low, the wheels are seen. The same picture. In one it's a takeoff, one it is a landing. You do not know. This is the same. At 8 you do not know what is happening. Take off, land down, come up ahead, you do not know. So as a power user, if you begin patient comes with 20 count and comes with 2 days later with 15 count, it is dropping. You're on safe grounds. You don't have to worry about this patient. Same when I said, is going from 8 to 11. You're worried.
Right.
Let's say you're dropping. Again here, from 4 to 2 you'll worry. From 2 to 4 you won't worry. So this is the trending that you want to see. Okay. And all the tests, CBC, whatever test you do, they have to be coordinated clinically. They have to fit in with the clinical picture. You have to be able to explain them as a jigsaw puzzle. They have to fit together. If not, think something. Go back again and think. They have to complement. And this trend is one of your most powerful trend in interpretation of the reports.
But if you have the reports at hand.
Yeah. Patient आके बोलता है मैंने 2 report निकाला, 2 normal है अभी. Still have. Okay. Labs reports can be wrong. Remember that in US the report wrong is 0.45%. 0.45%. That is 0.45 reports will be wrong in 100 patients, in 100 reports. So approximately 1 report in 200 will be wrong. This is in states. In India the story will be So labs can be wrong. So if you're getting something missing, you have to trust the lab, but you still want to verify. So the words would be trust the lab but verify.
Okay.
You have no other go. Sometimes you will send the patient to that lab, and the patient got the report, and you say they pay your report. You have to trust that the same. And think what tests and how often you want to do it. Like, in dengue you want to do it every day, or you want to do it twice a day, once a day, thrice a day. That is how you want to do the same, how you expect the picture to change. The same. And another thing that you want to do as a good doctor is, if you send your patient to the lab, dengue ka patient hai, you have to notify the lab that I am sending this patient, and if the platelet count comes below 20,000, you are going to ring me up. This is my number. I sent you my number on the patient's requisition slip. You will ring me up and you will notify me. So be proactive in those results. When you expect results to be really life-saving, phone up the lab. Tell them I want the reports. Blood sugars. You send someone's blood sugar, random blood sugar is being ordered, then your glucometer is not working, you want an immediate report. Tell the lab. You ring me up immediately, you do this report, you do this first and ring me up. Get it? So you set your boundaries for what results at what level you want to be notified and do it for that. That will make you a better doctor, a good doctor. Save money, unnecessary investigations not to be done. Like I said, sonography, only if you are seeing the extravasations. Or don't do sonography. I've given you enough clinical science to go by for the extravasation, so you can be safe on that. That's it.
The same.
Huh?
The same that we have one of the series.
Okay, this hopefully completes the series on CBC interpretation and fever. If there are anything more, please put up your questions on the chat and I'll answer them.